and at the moment I'm working in St. James's Hospital. My interest is geriatric medicine, and I did my diploma in Syncope last year. Thank God I graduated from double diplomas organized by RCPI. So I would like to share my screen here. Hopefully you can see the slideshow. Give me a shout if you cannot see it properly. So before we begin, I would like to address the audience mainly from medical students and NCHDs. NCHDs means non-consultant hospital doctors. I hopefully Prof. Rose and Kenny or other colleagues won't be listening to my YouTube online lecture here. To begin with, we will start with a syncope in recurrent falls. It's a common presentation in ED for medical admission. And I've been given a chance to look after syncope unit in St. James's Hospital for 4 months. So it's the only unit in the country that have this kind of specialty. So we will begin our lecture here with a definition of syncope, followed by 4 case studies, and also the common causes and common investigations, followed by common management, and we'll be look at into recurrent falls in elderly. My slideshow is around 20 to 21 slides, so hopefully I will spend around 3 minutes for one slideshow. First is a definition of syncope. Syncope is a total loss of consciousness due to transient global hypoperfusion, characterized by 3 things. The first one is a rapid onset, short duration, and spontaneous complete recovery. If you look at this diagram, which I picked it up in the syncope guideline ESC in 2009. Syncope in the context of a TLOG, you can have patients with loss of consciousness or without loss of consciousness, with falls and also semi-consciousness or altered consciousness, somebody with delirium, etc. And then somebody with these 3 items here, which I mentioned: rapid onset, short duration, complete spontaneous recovery. So it belongs to the diagnosis of TLOG, which is syncope. And it can be divided into traumatic and now non-traumatic. For traumatic, some sort of a brain injury, we won't be covering this lecture, this traumatic area here. For non-traumatic area, it can be divided into 4 categories. The first one is syncope. The other differential diagnosis for syncope is epileptic seizure. Surprisingly, we have a psychogenic TLOG, which accounts for 1/3 of the patients who came in with syncope or syncopenic and other rare causes. Somebody without these 3 items here, no rapid onset, no short duration, or no spontaneous complete recovery, they can have other comorbidities or other presentation, which is coma, or other cardiogenic problem. To make it interesting for this lecture, I would like to begin with a first case study, which is quite common in elderly. So I have a 84-year-old female with witness total loss of consciousness while visiting her hairdresser. She reports while getting her hair washed, patient lost consciousness. Prior to even, patient remembered that when reclining her head backwards, when she tilt her head backward, and she found it increasingly hard to keep her head in position and felt uncomfortable or some vague pain, some sort of a prodrome here. And then she said she felt well afterwards, didn't want to go to hospital, and however, her hairdresser insisted with no other similar presentation in the past. So from the collateral history, prior to loss of consciousness, patient told hairdresser she felt sick or nauseous. This is some sort of a autonomic activation. Witness got her a glass of water and then she went stiff. Sometimes people can see, people can present with some sort of a symmetrical jiggling movement, which might be which might be overlapping with seizure. Unresponsive for estimated less than 1 minute. She called ambulance with a recovery period around 3 to 4 minutes. And then she was looking pale after that with no clonic jerk, no vomiting, no incontinence, and no tongue biting. Medications-wise, she's on ramipril and also hydrochlorothiazide. The trade name is Converge, 10 milligrams and 12.5 milligram. She's on donepezil 5 milligrams once daily for anticholinesterase inhibitor, and she's on risperidone 1 milligram once a day for the mood stabilizer. Her BP lying standing, you can see the significant drop from 140/85 to 110/80 with no symptoms reproduction. The definition that we are looking into somebody with positive orthostatic hypotension is a drop of 20 millimeter mercury of systolic and 10 millimeter mercury of diastolic. ECG, sinus brady with QRS with QT complex, they're all normal. And then she was admitted under cardiology because of the ECG changes after second ECG, and on telemetry shows recurrent episodes of atrial tachycardia and atrial fibrillation for a few seconds, but no further syncopal episodes. She had her echo, which is normal, carotid ultrasound is normal, CSM supine, this is carotid sinus massage to trigger. There is a baroreceptor around the carotid sinus. So if you trigger it, you can see whether it is a cardioinhibitory response or vasodepressor response. But this one is not done for this patient. The same goes with the Taylor test. Most likely she has vasovagal syncope, and also she could have other abnormal conduction of the heart, and also so she has her ramipril and hydrochlorothiazide has been stopped due to orthostatic hypotension, and donepezil can cause bradycardia, and it has a high it has been linked with syncope, and patient has been put on propafenone with the intention to treat the atrial fibrillation. The next case is quite complex. So we have a 31-year-old gentleman who's been referred by his neurologist to Falls and Blackout Unit in St. James's Hospital, backdated in April 2014 with transient loss of consciousness. He had 3 episodes in the last 8-month period between December 2012 and August 2013. 2 events occurred while seated, and the other is in sleep. Patient has no significant previous medical history. With some arthritis on both knees, there was no history of vasovagal syncope in youth, and no family history of sudden cardiac death. Brother has epilepsy with after post-head injury. The first event backdated in December 2012. Patient was well, sitting on a sofa, playing with son. Suddenly got a severe pain in his right knee, immediately felt dizzy, clammy, and pallor, loss of consciousness for a few seconds with a quick recovery. The second event was in August 2013. Patient wasn't feeling great, suffering stomach cramps, generally feeling exhausted, went to bed. Doctor went to work him and found him with eyes open, trembling, pale, clammy. Took 1 to 2 minutes to rouse him, and then the wife noted about the jerky movements, which I mentioned earlier on, and he had also seen the incontinence of urine, which is activation of the autonomic function. And when he got up out of the bed, he vomited. The third event, 8 hours later, same description as the first event. So at this stage, family is not happy with him, so they called ambulance. He was admitted to hospital. He's not on any regular medications. He was admitted to Kilkenny in August 2013. He has a lot of investigations, typical investigations. If you are in the peripheral hospital or any other hospitals, you are getting CT brain, echo, Holter, routine EEG, which are all normal, and also the MRI brain is normal as well. So he's been discharged with diagnosis of epilepsy and has been put on Keppra, which is levetiracetam. And then he was referred to the tertiary center, which is Fabu. The first investigation is this, ECG, which is normal, active stand, which is normal, and then EEG table tilt test, in which you are doing table tilt test followed by EEG recorded at the same time, which is normal as well, to see if there is any evidence of epilepsy. And then he was on prolonged monitor for about a week. Same like Holter monitor, but this one is for a week, which is normal as well. So we deprive him from sleep, and then we did the EEG onto him to question the diagnosis of the seizure, and it's reported as irregular theta transients seen independently over both temporal regions, more prevalent on the right, raising the possibility of a dysfunction. But again, no definite epileptic activity is seen. EEG is quite sensitive, but you need to put it into a context to diagnose a seizure versus a syncope. So at this stage, after the sleep-deprived EEG, he could have a possible epilepsy, and then we proceed with more investigations. Whether should we put on the internal loop recorder, which is a prolonged monitor of the heart rhythm to be inserted below the skin, left pectoral area on most cases, and then usually it lasts for about 3 years until the battery dies. If you wouldn't catch the rhythm, you will replace the loop recorder again, or you might want to do a front-loaded Hell-Apti test. I'll go through with you with the common investigations after this with the types of table tilt test. And Reveal, which is the internal loop recorder, inserted in 2014. Nothing really remarkable with all asymptomatic for dizziness. There's no rhythm symptom correlation. And front-loaded head-up tilt test performed in February 2015. Positive response. You can see the 30 seconds of air systole with the exact symptom reproduction with jerking movements of the limbs. So this gentleman has a vasovagal syncope with a significant cardio-inhibitory component. We go with another interesting case in which I saw in Mayo before. So we have a 40-year-old lady, sorry, this one is in Falls and Blackout unit this year. We have a 40-year-old lady referred by the cardiologist from Limerick Hospital with recurrent falls over the past 4 years. So you want to take the full history taking, started from the first fall back in May 2015 in the evening. She was going upstairs and then she fell backward after a few steps, and she suffered from the rib fractures. Subsequent falls with you can see the pattern usually occurs on the daytime. She described as suddenly her lower limbs felt weak with no warning, no prodrome. She was aware that she's gonna fall with no loss of consciousness and no seizure-like activity, no jerking movement, no tongue biting, no urinary incontinence, no dizziness. And she admits that her sleeping pattern during the day is sleeping pattern is not regular. With she's sleepier during the day, and also she has other psych component here. She finds it very stressful. She's on the treatment for birth plan. She still hasn't. She wants a baby, but multiple attempts with no success. So recent fall about 4 months ago, she fell between the taxis on the taxi rank. She fell forward and hurt her palms. It means she knew that she's going to fall, so she put her palms forward to prevent her from injuring herself. She's on medication for birth plan. She's on vitamin C and iron supplement. So I did an Epworth sleep scale, which is 1, not that high, and with normal. So I look at all the investigations since 4 years ago. Normal CT brain, normal MRI brain, normal loop recorder, normal echo, and also we performed the front-loaded head-up tilt test, which is normal as well. So I discussed this case with Professor Rose and Kenny, my mentor. We think this lady has cataplexy, which is there is a psychogenic component in this diagnosis. She finds it hard to accept the diagnosis, given that this has been going on for 4 years with no other treatment. It's just the reassurance. The next case is the interesting case from Mayo. A 65-year-old male who presented to ED with a 1-hour history of collapse and loss of consciousness, followed by slurred speech and facial droop. He was gardening around 1:30 p.m. During the summertime, and at that time he was standing, and then he collapsed around 2 p.m. with a loss of consciousness, witnessed by his sister. His sister went for a holiday. She's a cardiac nurse in Chicago, and her sister woke him up. He didn't wake up, and then laid him on his back, and then she checked his pulse with no pulse, and she started. She wanted to start the cardiac compression, but then he woke up with a slurred speech and facial droop, with no loss of motor function. Arrived in ED, medical rush on call, got to see him, and at that stage his NIHS is a 1. With a normal CT brain, and it's decided not to thrombolize him, given NIHS less than 4. Rarely you will see patients with acute stroke presented with a loss of consciousness, unless it is a vertebrobacillar insufficiency. Patient came in who is very, very sick. And the other thing is, if you look at on the Rosier tool scale, you are minus, you deduct 1 point if the patient with loss of consciousness, and you deduct 1 point if the patient with a seizure. So medication wise, he's on Converge, amlodipine, olmesartan 20 and 5 milligrams once a day. No known drug allergy, routine FBC, UNE, including glucose 5.5. They're all within normal ranges. And he unfortunately, after day 2, he had an MRI brain, which shows left temporoparietal infarct and left subacute frontal infarct. It means it's a bilateral infarct, which is quite rare. Typically, you will get this patient with somebody with atrial fibrillation. So we did a echo to find out whether it is a cardioembolic, which is normal. Holter, normal sinus rhythm, and also, but surprisingly, when we did the vascular ultrasound Doppler, he has a bilateral carotid artery stenosis, right 80 to 99%, left 70 to 80%. So the plaque from the carotid artery stenosis was showering through his brain, and MRI carotids confirmed the diagnosis. So quite interesting, this man has stroke, ischemic stroke with bilateral carotid artery stenosis, and because he's not a candidate for thrombolysis, we put him on aspirin 300 milligram. He's been referred to a Mater Hospital for right carotid aneuploidy. When we talk about the causes of syncope, there are multiple causes if you want to remember, but you need to focus on 3 main areas. The first one is the you want to look at, you want to depend on the pathophysiological basis of the classification. The first one is the reflex syncope. The second one is the cardiac syncope. And then the third one is the syncope secondary to orthostatic hypotension. Reflex syncope, typically young female, 20, 30 years of age, with prodrome and good recovery. Cardiac syncope is the diagnosis. If you are suspecting someone with cardiac syncope, there is a need to investigate further, in which there is a high mortality rate. Somebody with cardiac syncope. And syncope secondary to orthostatic hypotension is common in a population, especially in elderly population with multiple medications. So we go first with the reflex syncope. It can be both, whether it is a vasodepressor or cardioinhibitory. Vasodepressor means, let's say if there is a change between the blood pressure and also the heart. If predominantly if it is a vasodepressor, so most likely this patient, especially in a young female, due to lack of water consumption or salt consumption, they can have this. Cardioinhibitory is some sort of a if you do the health, if you do the tilt test, whichever comes first. If you are doing a tilt test, you are monitoring the blood pressure and also the heart rate. If the heart rate goes asystole for a few seconds first, followed by the dropping of the blood pressure, so it means this patient has a cardioinhibitory of the reflex syncope, or they can have both. Or sometimes you might have a rare condition in which you have this some sort of an inappropriate reflex, in which your blood pressure, your heart rate tries to compensate to raise the blood pressure, in which your heart rate is not there to keep up with the venous pooling of the blood from lying to sitting or lying to standing. Again, cardiac syncope is associated with the high mortality rate. If you suspect a patient who came in with a syncope in ED, this patient warrants investigations, especially if they have abnormal ECG or abnormal cardiovascular examination. The first one is the common one is the structural cardiac, particularly aortic stenosis, with a high mortality rate once they reach the symptoms of syncope, angina, and dyspnea, higher than cancer. And then you have arrhythmia, which is quite tricky to diagnose. The first line is the ECG first. If you can see anything abnormal on ECG, such as a left bundle branch block or atrial fibrillation, the list goes on. Other rare cases such as Brugadas or prolonged QT interval. And then if the patient presents with seated syncope or lying or supine syncope, most likely they will have this arrhythmia type of picture, in which they warrant prolonged Holter monitor, 24 hours or 7 days, or followed by internal loop recorder up to 3 years. Or they can have this cardiac pulmonary, which is the pulmonary embolism. These all contribute to the low cardiac output, in which they will go to the low blood pressure and global cerebral hypoperfusion. And the other thing is, because of the volume depletion, somebody with dehydration or venous pooling in the leg, patient is on lecanidipine or amlodipine or inadequate venous return, they are all contributory to the syncope. Next group is the syncope secondary to orthostatic hypotension, common in young people and also elderly people, especially if they have a lot of medications that can cause low blood pressure, such as antihypertensive, or they have medications that can that can disturb the autonomic function test. They can have primary autonomic failure or secondary autonomic failure. Secondary autonomic failure, somebody with diabetes mellitus, somebody with recent adrenal surgery or Addison's disease, the list goes on, or somebody with recent surgery to the adrenal medulla, or that's a bit about the orthostatic hypotension. So common investigations, as I mentioned to you earlier on, common investigations in most hospital, somebody with syncope, you're getting CT brain, you're getting Holter, you're getting MRI brain, getting EEG, in which some of the investigations are not appropriate depending on the context of the history taking. 75% you will get from the history, and diagnosis investigations just to confirm the diagnosis. Common cheap investigation which will yield diagnosis. The first one is the 12-lead ECG. Dr. Muhammad Iskandar will go through with the ECGs in May 2017. So stay around with the tutorial. Followed by active stand. Active stand means you are checking the blood pressure while you are lying. After that, you are checking the blood pressure while you are standing. And the same goes with the heart rate. You want to see the appropriate response. The heart rate goes up while the blood pressure goes down, and then the blood pressure is stabilized back again. Somebody with orthostatic hypotension, you can see the difference. Heart rate is not keeping up with the blood pressure. The blood pressure stays low after more than 30 seconds or up to 3 minutes. And then followed by the tilt test. There are many variations of the tilt test. The first publication by Professor Ross and Kenny in the New England Journal of Medicine around 1970s. She found out about tilt test, and then to diagnose syncope, to differentiate whether it is a cardio inhibitory or a vasodepressor or a mix. And you can tilt the patient tilt to symptom, or you can give the patient GTN spray to provoke the blood pressure to go low, and then you want to see the symptom reproduction. And other variations, Italian protocol, head up tilt test, or tilt to symptom. We won't go into that detail today. The next one is the carotid sinus massage. Again, somebody with carotid sinus disease in elderly, their baroreceptors are not functioning very well. So if you same like tilt test, you want the patient to lie down, and then you ask the patient to turn their head to the left, and then you can feel the baroreceptors around the carotid sinus. It needs to be trained, and you can feel the carotid bulb between the two-thirds of the from the sternocleidomastoid angle, anterior triangle, and give a good massage around 5 to 10 seconds, and then lift up your hand while monitoring the ECG. You can see if they with normal response, people won't get asystole in elderly or in somebody with carotid sinus disease. You can see asystole more than few seconds, more than 5 or 10. So they need a pacemaker, PPM pacemaker, PPM VVD particularly. Next investigations we will cover after this topic, which is half-pipe maneuver, quite common in elderly with symptoms of vertigo, and which is quite good sensitivity and specificity in order to confirm your diagnosis of BPPV. It is a skill that needs to be mastered for all doctors and students. The next one is the ambulatory, usually 24-hour ambulatory blood pressure monitor. You want to monitor blood pressure For a patient, if you suspect the blood pressure is on the low side, to optimize the target blood pressure, particularly in the elderly. The cutoff point, according to the British guideline, secondary prevention 140/90. But again, with elderly with significant comorbidities, the blood pressure can be lenient to avoid them falling and breaking their hips. Next one is the 24-hour Holter monitor. It is useful if somebody presents with a syncopal episode frequently, at least once a day. But it's not useful somebody with syncope 3 months ago or 6 months ago. The next one is the loop recorder, which is external loop recorder, or the R test. You put on for about a week. Somebody with syncopal episode once in 6 months, or you want to diagnose atrial fibrillation. If the ECG cannot confirm it, ECG only record 4 beats, but loop recorder can be recorded around 1 to 2 weeks. The next one is the loop recorder, which is implantable, inserted subcutaneously. And it is quite small. The size is around 2/3 of your small finger. And then the last one is the autonomic function test, as we discussed before. Somebody with OH, orthostatic hypotension, prolonged steroid exposure, somebody with COPD, and they became dependent on the steroid. You can see whether their autonomic function is there or not. Common management, we focused on the common diagnosis. The first one is orthostatic hypotension. Again, look at ask the patient to drink water adequately, at least 2 to 3 liters a day, 1.5 liters before 2 o'clock. Salt consumption 2 to 3 grams a day, and stop the offending medications. Vasovagal syncope, it depends on the ECG, on the history taking. If it is quite serious, especially in young patient, or people who's driving commercial vehicle. If you diagnose them with the vasovagal syncope with cardioinhibitory episode, then it's a pacemaker. If they have a vasodepressor, so you can advise them with the non-pharmacological management. The one that is proven to be successful is the physical counter maneuver. Let's say if they have this pre-syncopal episode with prodrome, you ask the patient to squeeze their bum, or to have some sort of a stress ball to hold it, to squeeze the stress ball, so the blood pressure will go up. And then if they know that they're going to fall, they need to sit down or they need to lie down, so to avoid syncope. Again, for carotid sinus syndrome or carotid sinus hypersensitivity, pacemaker is the treatment. With BPPV diagnosed by Hall pipe maneuver, you need to put on do airplane maneuver, putting patients on SERC, SERC, beta histine 8 mg TDS won't be beneficial for patient. It will sedate the patient more, which is not advisable. You might want to see on the YouTube about the airplane maneuver, EPLEY. Medications commonly used in somebody with orthostatic hypotension, not on any antihypertensive, or you have stopped all the culprit agents, you can put on fludrocortisone, typically dose 0.1 milligram up to 0.3 milligrams once a day. If it is not enough to control the symptoms, you can put on midodrine. Be careful, somebody with history of heart failure, you need to be cautious because midodrine can cause fluid retention. Antihypertensive medications, they all are major major medications that can cause syncope, especially bisoprolol or tamsulosin, somebody with BPH. And vertigo medications, again, I wouldn't advise somebody to put on SERP or Stimatil for BPPV. Polypharmacy is a big thing in elderly, and medications that can prolong QT interval, such as antipsychotic medications or antifungal. So we move on to recurrent falls in elderly. The time now is around 8:30. This is a vicious circle of falling in the elderly. Somebody with frequent falls, 80 years of age, a female or male. Again, you are looking into 3 possibilities. If you want to take the history, ask the patient before before the episode, during the episode, after the episode, witnesses or collateral history. 3 main things. The first one is the environment, which is not safe for patients, elderly patients. Bedroom or bathroom upstairs, they need to use stairs with no rails or shoes. Or the other thing is the gait impairment, including freezing, somebody with Parkinson's disease or Parkinsonism, or postural instability, somebody with orthostatic hypotension. Subsequently, they will after the fall, they will suffer fractures, especially hip fractures, or other injuries such as laceration to the face, or shoulder injury, or collis fracture, or he or she might fear of falling. That will lead to immobilization, which is not advisable in elderly, because with somebody with immobility, they can cause insomnia, social isolation, reduced fitness, constipation, and weakness, or will lead to osteoporosis due to lack of inadequate vitamin D exposure. And then they will end up in nursing home admission with depression and high mortality risks. Or they will have this some sort of rapid disease progression with a lot of comorbidities and cognitive decline. That's what we don't want in elderly. As I mentioned before, the pathophysiology of falling, it can be a lot of factors. The 4 main one is the cognitive impairment, such as somebody with Alzheimer's disease, or physical impairment or disabilities, or environment, the footwear, the floor, the lighting, or the protective factors, in which these are the elements that you want to treat the patients, whether you need to treat the underlying disorders, to limit the medications in polypharmacy, to stop alcohol, and also to optimize environment by OT home visit, and also physical therapy and occupational therapy. This is the algorithm to diagnose falls. I know it's a bit complicated. We are going through it one by one. Again, let's say if I give you a case, 84-year-old gentleman who has 3 falls over the past month, and then so it means it is a recurrent. So take the history taking, whether it is a similar pattern or a stereotypical pattern. And then if it is multiple, you need to analyze the pattern separately. And then you need to look for the risk factors. Or it could be spontaneous, some sort of a mechanical fall. Or you need to look at the old medical notes. It might be clues from the background history or medications. And then you need to identify the risk factors. It could be extrinsic, which is environmental, or intrinsic. If it is extrinsic, again, home visit by OT, and then you need to you need to do necessary precautions. And then if it is intrinsic, which is patient related, ask the patient clearly whether he or she might have syncope or not. And some patients, especially in elderly, they won't remember whether they have a syncope or not because of the memory, or they wouldn't realize they had a fall, and then next time they remember they were on the floor again with syncope, lasted for a few seconds, not more than 4 minutes. And then if it is a syncope, you need to proceed with the syncope pathway. If they deny any TLOC, you want to ask about the do you have some sort of a funny turn when you look to the left or to the right? If you are on the bed, do you feel funny, or do you feel dizzy, or do you feel the room is spinning? And if you think it is a pre-syncopal episode with prodromes, again feeling sick, feeling nauseous, bad smells, or postprandial, so you think it's syncope, you proceed with the syncope pathway. If there is no prodrome, or you think it's more into vertigo, so you may proceed with the whole pipe maneuver and airplane maneuver for the treatment. With no preceding funny turn, ask the patient to walk, check whether this patient has a gait or balance disorder, and then if they walk perfectly healthy or normal, you can just say there's nothing major with this patient. And if you think there is a gait or balance disorder, so you want to do more about you want to see whether the center of mass or the center of body, whether tilt forward, stooping with tremor one's hand, clockwise turning, you're thinking of Parkinson's disease or Parkinsonism. And then if it is the patient focus mainly on the legs, such as diabetes or mononeuritis multiplex, you're looking into neuropathic pathway. And then chronic diseases that are often associated with falls. Again, somebody with visual impairment, cataract, diabetic retinopathy, BPPV, or vestibular neuritis. And also the other thing is somebody with diabetes mellitus, in which they are on metformin, they might predispose to vitamin B6 deficiency. Again, with diabetes, you might lose the sensory polyneuropathy on the legs. In Parkinson's disease, again, it's all extrapyramidal. With motor stroke, somebody with lacuna infarct or MCA infarct, they can have these symptoms, which is hypertonia, spasticity, and in which it might impair the mobility. Alcohol abuse, again, is common in Ireland. I'm not sure in the UK. Somebody with somebody who drinks alcohol more than 21 units per week. You can see all the cerebral signs, including vertical tremor, and then ataxic gait, and raise gamma GT. Myasthenia gravis is one of the diseases in which we encounter it every day in the clinic. It's usually patients around 40 to 60s, or they have on a prolonged steroid myopathy, such as a patient with a diagnosis of giant cell arthritis or COPD or asthma or bronchitis. They can have this steroid myopathy, especially on the proximal part of the body. And the other thing is the Alzheimer's disease, in which they have the cognitive problem, or they have combined factors. Other things, again, environmental risk factors. You need to ask them, how did you fall? Did you trip onto something? Where did you fall? Need to get a thorough history. again, with the psychoactive drugs, somebody with delirium or somebody with a poor sleeping pattern, stop the benzodiazepine or ask them to wean off these tablets and try non-pharmacological treatment of the sleep problems. Again, with the cataract and glaucoma, ask them to be seen first by the optometrist, followed by ophthalmologist if necessary, and then to have the cataract surgery. With orthostatic hypotension, physiotherapy is needed to treat these patients with assistive devices, such as they can use a walking stick or three-wheel rotator or Zimmer frame for gait and progressive balance training. Adequate hydration and avoid precipitating circumstances, especially somebody who's dehydration. Again, as I mentioned to you earlier on, a few maneuver that can avoid avoid syncope, somebody with vasovagal syncope, in which you are standing with crossed legs or regular tiptoeing. Compression stockings, I'm not sure how effective it is, but it is quite problematic for patients to put on the compression stockings. And then fluorocortisons, midodrine, and exercise. And then another few minutes. Osteoporosis, you need to put the patient on the anti-osteoporotic treatment depending on the DEXA scan. Few options available. First line treatment is bisphosphonate, alendronate, or zolendronate weekly tablet. And then after 5 years, after 5 to 7 years, you might want to switch to other anti-resorptive agent or anabolic agent, depending on the repeat 2-yearly DEXA scan. Or you can have other anti-resorptive agents such as Prolia, which is denosumab monoclonal antibody, 60 mg 6 monthly. The second option for the anti-resorptive, which is IV zolendronic acid. It can be given yearly for patients with intolerant to oral bisphosphonate. Oral bisphosphonate can cause reflux, which is quite debilitating for patients with polypharmacy. And then the newer treatment, which is parathyroid hormone injection, which is the brand name is the Forsteo, 20 microgram once a day subcutaneously for 2 years. That one is for the anabolic steroid to help with the bone formation. Besides DEXA scan, you can check the patient with the bone markers such as CTX or P1NP. The other thing is make sure that the patient has the proper footwear, and with the cerebrovascular disease, stop smoking, treat hypertension, dyslipidemia, treat the daily exercise. And balance problem, there is a good tool to measure the balance problem in elderly, which is BERG balance scale, and treat the cause if possible. Again, physiotherapy with the physio session, and provide external support such as stair rails or walking aids. Age incontinence is common in female with multiple birth, or treat the underlying cause, or you can use the oxybutynin if necessary. Cognitive impairment, so far there's no definite treatment for Alzheimer's or other cognitive impairment. Anticholinesterase inhibitors such as donepezil, or the other thing is the memantine is licensed for Alzheimer's disease, but not for vascular dementia or other subtypes such as frontotemporal or Pick's disease. The medications they are used to slow down the progression of the illnesses. can be diagnosed by a tau protein level in the plasma serum, but not available in UK and Ireland. It's only in the US. And again, the other thing is the positional maneuvers, as I mentioned to you earlier on, airplane maneuver or habituation exercise. Again, so far we have covered syncope, the definition, a few great case studies, common causes of syncope, common investigations that have been used widely. Again, you need to use your judgment. Investigations are tool to guide your diagnosis and the common management. With the recurrent falls in elderly, quite common presentation for elderly 65 and above in ED. Again, you need to stop the vicious cycle, or it will keep repeating and will make the patients more debilitating. Again, the pathophysiology of falling is overlapping with the syncope. And again, the diagnostic algorithm, as we mentioned earlier on, in which this lecture is available it's been recorded and can be looked at after this. And again, chronic diseases and falls such as Alzheimer's disease and also Parkinson's disease, and secondary prevention to stop the vicious cycle. These are the references. Within these 8 to 10 minutes, I'll be happy to answer any questions if there is any.